All right. Okay. All right, I got it. All right, is anyone there? Dr. Matarj, we have a good look at the back hallway. So hopefully we'll have a live case from Dr. Matarj. Guess I should get on the headset. Well, there he is.
Anything they probably see us there.
A little fuzzy, but I think you'll clear up. Can you hear us okay?
Guys, can you hear me?
Yes, we can hear you.
It almost looks like a transmission from the moon.
No, that's okay. You don't. Okay. I'm going to talk to some people, and you don't have to pay attention to it, okay? Okay. Yeah, he thought I was talking to him. Okay, are we on?
Yes, you're on. A little fuzzy, but we can hear you.
Okay. Who am I talking to?
That's Jack Chamberlain. How you doing?
Okay, who do you have on the panel?
We got, can you hear us? We got Dr. Winscott, Davis, Stanley, Abbas, Rosales. Did I miss anybody?
Okay.
I don't want to scare you, Amir.
Tom, I'm glad you're there. Anyhow, we have a change of scenery here. We were preparing two distal vessel cases for you, and we lost both of them. And one of them came to ER with stroke, so that we couldn't work on her today. And the other one had infected toe, and they pressed me to finish him to go to OR. So we have very interesting cases here for you today. To start with, we have this gentleman who's 91 years old, very well kept, and he complains of buttocks claudication on the right and calf claudication on the left side. He has no diabetes. He has mild coronary artery disease that's post-stent, and he has hypertension controlled by medication. So we run a complete set of angiogram on him. And before I show you the angiogram, I'd like to introduce my compact team over here. Robert is my first assistant. Yeah, and Linda is my second assistant. Where is Don? Don is the operator. We have Rachel and Chrissy are all nurses here today. But anyhow, so we're going to show you the angiogram. Go ahead, Robert. I hope you see the. Do you see the angiogram?
Not yet.
Okay.
Now we do.
Now? Okay. That's the aortogram. And you see there's a little bit aneurysmal dilatation of the aorta on both common iliac arteries. Nothing really exciting. His renal arteries are okay. Next one. On the left side, on the right side, I thought prior to angio, I thought he's going to have occlusion of the right iliac artery because he had absolutely no pulse, no femoral pulse on the right side. But it turned out to be a near total occlusion of the external iliac artery, very ugly looking stenosis, and then diffuse stenosis of the rest of the external iliac. Next one. He has diffuse stenosis of superficial femoral artery on both sides. And he's, show me the next one. On the left side, he has a very bad lesion in the adductor canal. And he has problem on both sides, but the left side is really bad. And next one. His distal arteries are okay. Anterior tibia is occluded on the right side, but on the left he has 3-vessel runoff. And so here we are. I'm going to do an angio in oblique position for you to see the lesion. Okay, you see the tight stenosis, very irregular, may even have some thrombus in it.
Yeah, it looks like there's a little bit of a filling defect, and then there's a very short.
Exactly,
lesion.
yeah. And I'm going to cross that. What I have here is a quick cross catheter and a glide wire. And so I'm going to very gently try to go to that stenosis, try not to dissect that.
So Samir, is your
So
plan to
Amir-
go ahead and treat the SFA today?
That was my question.
Samir, are you planning to treat the SFA today in this procedure?
Yeah, I'm going to do his left SFA today in the afternoon. Here we go. I can change that now to 014 wire because I'm going to put an IVUS in and take a look at that. That's stenosis. Show you the.
What what
I-
size IVUS are you going to use?
Is one. Yeah.
The peripheral 018?
Yeah.
I think the question was on the right leg, are you just going to treat the iliac? Or do you plan on
Yeah, I'm going
treating the
to
SFA?
treat the iliac. One thing I was going to ask you and ask panel, you see the size of that internal iliac artery, and the branches are mostly intact. Why this guy has claudication of the buttocks?
Was that on just the left side he had buttock claudication, or?
No, right side.
Oh,
The
the right
left side he has calf claudication.
Oh, okay. Yeah, I think it's hard to explain that. What do you guys think?
No, but in the image that we see from here, in the right external iliac, it's hard to see the gluteal branches. I don't know if you have a different view, an opposite view, an LAO view of the right side where we can see the superior and inferior gluteal branches. I couldn't see them.
Yeah, but yeah.
Amir,
Okay, yeah.
Amir, this is Tom, and I don't mean to
Yes,
upset
Tom.
you, but I'm curious. Other than maybe you want to do this in the afternoon, but would you normally, or would you just approach this from the right side, fix the iliac on the right from the right position from the right femoral axis, and then go up and over and treat the SFA at the same time?
Well, Tom, we didn't know that's what it was.
Okay.
We did the angio from left side, expecting to have right iliac artery occlusions.
Okay.
And iliac artery occlusion, I always like to do them from a contralateral. I like to come from above rather than below. And because the incidence of dissection is a lot less, or going to the extraluminal is a lot less if you're coming from above rather than going from below. And so that's our routine approach, that we always do the angio from contralateral, not only for doing the recanalization, it's always a nice policy to do the angio from asymptomatic side, because you don't want to do anything
You know, the only thing
to the side that is symptomatic.
the only thing I worry about is coming from above on these, if it's totally occluded or subtotal like this is, and I think this is an easy to dissect this vessel when wiring it because it's so tight and it looks like calcified. So, coming from below, at least your dissection plane's downwards, and I think less problematic if you if you're causing a dissection rather than from above, because your blood pressure is going to potentially extend that dissection plane downwards. So that's why I usually do it from below.
We are right. Yeah, Tom, we're right now into the lesion, and as you see how much the lumen is reduced now.
Is that in the past the filling defect?
We're just past it right now. And here we go right into the lesion, going above the lesion now. That's above it, and going right through the lesion.
Amir, I have a question for you. This is Samer. Putting a stent in that iliac and just interfering below the knee or in the SFA at the same time, are you concerned about dislodging that stent? It's fresh stent, you put it in. If you want to do any atherectomy device in the SFA, there's a chance that, you will move this stent. I usually wait like 4 to 6 weeks.
Oh, you mean if I go from right side after this is done?
Yeah.
There is a possibility, but not really that bad, because his arteries are big. And so he will allow us to we have the option of going antegrade as well. But when I looked at the angio and he has such a diffuse disease, I thought I might have to treat the whole SFA. So going from the contralateral would be a lot easier. And there was another way of doing it, was to just balloon this, then go from the right side contralateral, finish the left leg, then on the way out, stent the right iliac artery.
Right,
So
That's
that
generally my
was,
approach as well.
if I wanted to do everything in one setting, probably that's what I would do. And just balloon that to give me a luminal gain, then puncture the right common femoral, go contralateral and finish the left leg, then drop the stent on the way out in the external iliac.
Amir, could you
But
talk
for
about
Dino's
that?
sake,
Could you talk about that IVUS results that you have there a little bit more? Because it went quickly, and I was surprised. It looks like there's a filling defect there. I was expecting a lot more calcium, and it didn't look like it, at least on that first point. I was surprised.
Tom, I didn't see. I was expecting to see a lot more as well, but it looked like they were all soft plaques.
Yeah.
And so the next question probably would be, would you try to debulk this lesion before you balloon it? And now looking at the IVUS, I think that's a soft plaque and respond well to balloon dilatation, we're going to stent it anyhow. So yeah, as long as we gain the lumen, that would be enough. I originally looked at it. I was thinking about putting a Viabon through the whole external iliac artery, and I still might do that. But the only concern about the concern that I have about this anatomy is the transition between the common iliac to internal iliac arteries, and definitely trying to preserve the internal iliac artery. So there are different ways of doing that. One is that just put the balloon expandable stent throughout, and or if you want to do a Viabon, do the Viabon all the way up to close to bifurcation, then put a bare stent from that point crossing the internal iliac going to the common iliac artery. So that way you get good sealing and also preserve the internal iliac artery as well, and you don't miss anything right at the very proximal end of the external iliac artery.
Amir, would you please play the ultrasound one more time? And if you can
sure.
display the angiographic image on one side and the ultrasound on the other.
Yeah, sure.
And while you're
Okay,
doing that,
here
could
is-
you comment on why you feel a need of Viabon? To me, it looks nice and big. It's on a curve.
Because
it's short.
I have a large number of external iliac lesions treated with Viabon. The rate of patency is great. I never had any reocclusion of external iliac arteries, and the flow rate is very good. You know, with balloon dilatation and just a regular stent, the flow rate is not as great as when you have a Viabon in external iliac. And I think if one place external iliac, if I have to pick up one indication for Viabon stent graft, that would be in external iliac arteries. They do very well. The result is good. I haven't seen any restenosis with them. Even even you don't have any high incidence of edge stenosis with that, as you see in superficial femoral artery. And I guess it's because
What's the
bigger
diameter of it? It
arteries
looks huge.
better. Well, for this one, probably you need a 7 to 8. Remember, the lower end of this iliac artery is a lot smaller than the upper end of it. So there are many different ways of doing that. You can put a 7 that matches the lower end of the external iliac artery up to short of upper end. They go with a large atrium stent, overlap that one, then you can tailor it very nicely. You put one atrium stent that is a good size and as a perfect size for proximal end, and then the lower end of it, it is in Viabon, it just tapers down to that size. So
Amir?
that's a very nice way of doing it.
Amir, you've been doing this longer than I have, and your eyes are probably a lot more attuned to the sizing of these things than I am. But the beauty is you have an IVUS. You can just measure it off the IVUS completely from EMDM.
Yes.
And there's no guesswork in it
sure.
with that IVUS that you have.
Sure.
So we could,
Yeah,
if
well,
you play it back up
that
there,
was-
because I was measuring it as you were doing it. I think it's bigger than 7.
Yeah. That was one of the reasons we put the IVUS in, to give us exact measurement.
And I think
We
that's a great
already have
idea.
external measurements, but we're going to read it with IVUS.
What
And
size
IVUS will
sheath
give
do
us
you have right
exact-
now, Amir? What size sheath do you have?
Huh?
What size sheath do you have now? The size of
What
your
size
sheath.
what?
Sheath sides.
Yeah.
Oh, sheet I have a 7 French sheet.
The 8 needs 8, right? 8
Uh,
Viabond
8,
needs
I
8.
think, yeah, but I was thinking of a 7 Viabond if I want to use, and that will go through 7 very nicely. Yeah. And, well, we're going to measure it right now and see why don't we measure this right at the upper end of it.
That
Let's see the-
tapering size, I
we
would think
see
you could
the,
get by with the atrium that you could put in small but make bigger at the top. Just do one single stent, maybe.
Yeah, okay, can you give us a measurement now? Vessel, yeah. Wall to wall,
Yeah, that's huge.
Yeah, it's big.
yeah.
Now, Amir, what would be the problem putting in a
Now
smaller
let's
Viabond?
look at the, let's look at the yeah, common iliac. Let's see what size that one is. Uh-huh. That's 12.3. One.
So that's a pretty big artery. What's the outflow
That's
look
a
like,
very-
where the stent would be placed in the outflow? Because that even looks like a fairly good size outflow.
I think that's aneurysmal, that's
Let
right.
me see, if we end up here with stent at this point, let's see what size stent we need. Okay, I think that's the size that we anticipated, that we have to have 10 for there.
So in this guy's age at
Yeah.
91 and the functional restenosis rates of stents in the iliac arteries that large is pretty low over a 5-year period. Do you think rather than putting in a covered stent in there, wouldn't you be better off just to put a self-expanding and balloon it up?
I believe no matter what you do, you're going to get a good result, you know.
Well, it's in your
because
hands, Amir, so I'm
considering-
convinced of that.
Yeah, considering his age, considering the size of the artery, considering that how well iliac arteries do, even with balloon angioplasty. And regardless of what you do, you're going to get a satisfactory result as far as his
I mean, and
symptoms
if this was
concerned.
more heavily calcified on that IVUS, I might be more
Yeah.
worried about putting in a covered stent in there just because of the perforation risks and things to that degree. But that IVUS, I think, really helped you, not only sizing, but
Yeah.
what the morphology was of that plaque lesion.
Samir, we got about 7 to 10 minutes or so left for the live
Yep.
transmission.
Okay, let's give me that 7mm balloon. Let's just dial it with that first.
I think one of the discussions we need to have is just the importance of sizing, especially with stent grafts. And we know the risk of problems with stent malapposition with Viabond, and this is a very large vessel, like you said. I think a very large non-coated or non-covered balloon expandable or self-expanding. This portion we're going to be stenting here is very straight, even though it's an external iliac. I think you could place a balloon expandable or a self-expanding here, and we could argue about that, but probably either one's going to be just fine.
Yeah, you just don't want a undersized Viabond. An atrium you can play with. You could
But
miss a
also,
little.
once you start post-dilating an atrium to a vessel this large, it is going to shorten some.
Yep.
So you have to take that in consideration as well when you're trying to precisely place this and not cover that internal.
You know, I always think about, he's 91 years old. I know, like, there's not too much calcium. But those arteries at 91 years old, you don't know how they behave after you balloon them.
Right.
And we know that this is 10 millimeters vessel. If you have a rupture here, you really need like a 10 millimeter stent to close it, otherwise,
Is
you know,
this,
and he doesn't have the right size of the sheath.
Correct.
Yeah,
So-
but at that time, he can always, if that happened, I don't think it's going to happen because I think that would be more likely on the calcium. He can always put a balloon in there, seal it up,
understand.
and then come from the right side and go up. I think that would be the approach for a bailout. But
Can you go off of that?
Yeah, it's a long
then I can
tapering
get the
segment where
others.
the size goes from 13 to 7. The decision is going to be where to put the proximal end of the stent, so you can match the size to that exact location. The difference is probably 5 or 6 millimeters from the aneurysmal segment to the turn of the external iliac.
Well, that's like we were talking. I think either option is really good. You put a large, oversized self-expanding there, and it's going to taper itself. You put in a large balloon expandable, and you can taper the stent as you want to with multiple balloons if you want, and tailor the size of the stent. But I think that a non-covered stent here would be keep your options more open.
Absolutely, I agree with that.
The point was very well made about contingency planning, Tom, about whether you can balloon tamponade off a perforation, and here, Samir's going to treat the other leg anyway, so there wouldn't be any harm in going ahead and getting access in that right common femoral and having multiple ways to handle a disaster if you had that, since you're going to need that access later in the case anyway.
Yeah, that's where I want to be. Yeah.
What have you decided, Samir?
Okay.
So Amir, what have you decided here? What are you going to be using?
Well, right now I'm dilating it with a 7 millimeter balloon,
Okay.
and after dilating that, we'll do an angio-C. How does it look like? Then I'll probably put a just bare stent, and I can put a 10 millimeter by 10 cm long, and then check upper, see how far it goes. And the upper end of it, it might need a short 12 millimeters.
So, Amir, was there something on the IVUS that made you want to balloon that far distally, or you just based that on the angiogram?
No, that was angiographically, distally, was very narrow. Now it is on magnification. You see it as a good sized artery, but on original angio, it was very narrow. It was very, the stenosis was going, it was very diffuse stenosis going all the way down to the common femoral. Common femoral was much better size artery.
Amir, we're running a little short on time. I think maybe what we'll do is let you work, and we'll cut away and do a talk and come
Why
back to
don't
you, okay?
Yeah, go ahead, and next time I'll see you, I'll just show you the result.
Perfect.
Sounds great. We'll go ahead and move into our lectures, and we're first going to have Dr. Abbas, and he's going to talk to us about all the different options for lesion treatment below the knee.
Thank you again for having me here. So I'm going to try to talk about all options for treatment below the knee in 10 minutes. These are my disclosures. I don't think they are related to the subject here. Our objective for this talk, we're going to have a little introduction, talk a little bit about anatomy, some clinical and technical consideration, what's the options for treatment, and then we conclude our talk.
Is this on?
So the infrapopliteal artery disease, commonly seen in patients with diabetes, chronic kidney disease, and elderly. These are usually high-risk patients. And the concern about the below-the-knee disease, those patients high risk to develop critical limb ischemia. That's why we take them seriously and try to treat them aggressively. I want to just point that surgery is a great option. Until now, we say for a healthy patient with no comorbidity, I will say a surgery may be your first choice. Now, who are the people that right now, based on clinical data, will treat as a first-line therapy with endovascular approach? Those are the patients that they have significant medical comorbidity, not very long life expectancy. They have increased risk of surgery. There's no distal target for bypass, and they don't have like a venous conduit. Those, so far, based on the data, are the ones that we treat them with first-line therapy as an endovascular. There are a lot of data coming out to consider endovascular treatment as a first option for even less risks than patient, but still to be proven. So we're all familiar with the Rutherford classification, and I put this because I just want to say classification 0, 1, and 2, those are, and 3, those are claudicants, and I'll go back to this, explain why I put this here. So who will benefit from treating below the knee based on the data that we have so far? Those are advanced, as I said, disease patient like Rutherford class 4 and 6, when you have a resting pain or a tissue loss, if they have a systolic ankle pressure less than 50, or that transcutaneous oxygen pressure less than 30 millimeters mercury. And I took this from a recent publication at Sky, and the reason I said yesterday, Miguel had a live case about a tibial disease, a single vessel disease below the knee, and the question was, do you treat patients with tibial disease for claudications? And I just want to read the first paragraph. Moderate to severe claudications, those are class 2 and 3, with 2 or 3 vessel disease, all the tibial arteries involved, it's appropriate to treat it. Of course, there is no randomized trial for that, but that is what we believe now, that there is something called tibial claudications. If they have 2 to 3 disease, they're all involved, and they have moderate to severe claudication. No matter how much treat above the knee, you want to treat below the knee to achieve your goal. Now, what's the goal? Again, establish the flow, of course, normalize the ankle brachial index, the torr perfusion more than 30 millimeters mercury, and the oxygen pressure more than 40 torr. Those are your goal when you treat below the knees. What are our options? First option, PTA. It's the current standard therapy. It's easy to use. We have a low-profile, flexible balloons. The ability to cross these lesions. We can treat focal, multifocal, diffuse occlusive disease. We don't have a lot of clinical data, and Achilles here is like restenosis. And the people, as I said, with chronic kidney disease and diabetes and all, their high risk for restenosis. So plain balloon angioplasty, although it's the gold standard right now for therapy below the knee, I don't think the results or the long-term patency is that great. This is just a simple example from a case we did about a couple weeks ago. You can see that totally occluded in the posterior tibialis and distal anterior tibialis, diffusely disease and totally occluded, wire plain balloon angioplasty, and you can see established great flow to the foot. How long it's going to stay open, I don't know, but at least, treating a critical limb ischemia with this type of flow, results will be great. Cutting balloon angioplasty. Several modified balloon have been used, whether cutting balloon, scoring balloon, flavored balloon like chocolate and all these kind. And there is no comparative data to use those balloons below the knee. The studies above the knee were not like very positive, but I will say you can use those type of balloon as for the lesion that you did not achieve a good results with the plain balloon angioplasty. You got to think about the cost. And as I said, there is no comparative evidence. So I don't think these balloon can be, we have an excuse to use them as a first-line therapy. You always have probably to use them as adjunctive therapy. There's a lot of them. I use them all. They're great. You can achieve. But again, probably we don't have enough data to say this is the first-line therapy to treat below the knee. Drug-coated balloon, we're excited about that. As you've seen yesterday and the day before yesterday, that the balloon has a drug on it, and it's anti-proliferative drugs.
When you inflate it for 30 to 60 seconds, probably I think the Medtronic balloon 180 seconds, the drug goes into the adventure and stay for probably weeks, maybe months. And the concept inhibition of the intimal hyperplasia response to the arterial injury with the balloon angioplasty that will limit the the clinical restenosis. And that's a concept, as you say, you have the balloon, you have the excipient, and the drugs go to the wall, stay in the wall, and does the job. The Lutonix balloon is the balloon that's going to be available for below the knee. I think it's coming by the end of 2016 or maybe the beginning of 2017. Atherectomy. When do you use it? The inability to dilate the lesion. With balloon angioplasty, you're taking a risk of dissection or restenosis, vessel rupture. If I want to achieve a greater luminal gain, less need for bailout stenting, and maybe, we don't have data, but maybe long-term patency is better. Again, also with doing atherectomy, you improve the vessel compliance, which allow you to use adjunctive therapy. The clinical efficacy of these devices remain to be proven. As I said, we don't have a randomized trial yet. Currently, there is below the knee, I'm talking below the knee, there is no comparative evidence to support the use of any atherectomy device in infrapopliteal artery to improve clinical outcome. And we all know that. What are the options? Multiple, whether you can laser, rotational atherectomy, orbital atherectomy, or the turbohawk directional atherectomy. The laser, I think trial, the last C2 trial, John Laird, 6 months results, 145 patients. 41% of those patients were infrapopliteal, and it's actually impressive, 92% limb salvage in 6 months. Jet Scream, again, great device. It's a front cutter with a active aspiration. I will say probably the use of it above the knee is more than below the knee, but you can use it safely in the proximal tibial artery. I will say this is my device to use below the knee, orbital atherectomy. It is a 30 micron diamond cutting. The sanding effects which treat the disease and leave the healthy vessels create a micro particle that doesn't affect clinical significance of embolization. The device came on the market with the Oasis. However, they have a calcium 360, which 100% of the patient below the knee, and it shows it's very effective with good results. And the reason you can see this is the anterior tibialis into the distal pedal artery. You can wire that, do a little bit of orbital atherectomy with a low inflation of balloon, results great. This is a patient, actually the date is there, June 25th, 2015, from our lab, critical limb ischemia, totally occluded distal pop into the anterior and the peroneal, wire with orbital atherectomy, a small balloon, 3O balloon, and good results. The directional atherectomy is another device. It's also been studied. The definitive LE has a lot of patients below the knee. I use it in the proximal. This is the patient who has, if you see on the left side, the totally occluded anterior tibialis, single vessel runoff. We went from the pedal artery, snared the wire, and did some SSC with good results and low inflation of the balloon. Again, another case of anterior tibialis, the luminal gain that I talked about with a less risk of dissection or perforation with a plain balloon angioplasty. The stenting, I mentioned this because maybe in Europe, the data that we have for randomized trial is actually drug-coated stents, and they showed very good results. However, this is a multi-analysis. It showed that the freedom of target lesion revascularization did better with drug-coated stents, and also the symptoms improved, and there is the major amputation was less. This is with the drug-coated stents. There is the Destiny trial showed good outcome. However, those are a very little number of patients. So when we took it to the Excel trial, which although I have to say this is a self-expanded stent, this is not a drug-coated stent, they did 700 patients, and the results were not as good. Based on this, I will say currently the use of stent in the infrapopliteal artery is still under, I will say, scrutiny, and felt to be most effective in focal proximal lesion that fail primary patency. So, conclusion, critical limb ischemia is a prominent clinical indication for treatment of infrapopliteal artery. Revascularization is important to relieve symptoms and limb salvage. Balloon angioplasty currently is the current standard of care. Bailout bare metal stent or drug-eluting stents has to be after failed first-line therapy. Studies are currently enrolling the patient to address the use of combined strategy, whether atherectomy and drug-coated balloon, and we need more data regarding use atherectomy devices, drug-coated balloon, drug-eluting stents, and bioobservable stents. Thank you.
All right, excellent. Why don't we're not going to go back to the live courses yet. They're working on the camera. So why don't we continue with Dr. Winscott here. He's going to talk about, I love this title, Lost in the Subintimal Space Below the Knee. So carry on.
Thank you, Jack. I'm John Winscott. I'm a cardiologist from the University of Mississippi, and I spend the vast majority of my time treating critical limb ischemia, which, as you've seen today, is a below-the-knee problem. And so you end up treating a lot of occlusions below the knee. And so what I thought we'd spend our time today talking about is when you're crossing these CTOs below the knee, you're almost for sure at some point going to end up in the subintimal space. And so what we're going to talk about mostly is how to stay out of the subintimal space, but then once you get in the subintimal space, how to escape from that space and still be able to revascularize your patient. So we know below the knee occlusions are very common in critical limb. And one of the more common reasons to fail to revascularize that limb into the correct angiosome is the inability to cross the CTO. And these are very challenging lesions for multiple reasons. They're often very long occlusions. They're smaller vessels, so sometimes harder to treat and re-enter because these are 2 to 3 millimeter vessels as opposed to 4 to 6 millimeter vessels above the knee. You're often dealing with multiple lesions, tortuosity, especially in the proximal anterior tibial and then down in the foot itself into the pedal arch. You have problems with spasm, especially in women. You're working a long way from the sheath, and you have fewer options for re-entry. We had a nice talk earlier this morning on the re-entry devices available, but most of those are only available for using above the knee. So I'm going to highlight some of those that are available below the knee. If you look at options for crossing, we had a nice talk this morning on the different crossing catheters, so I'm not going to spend any time on that. But there are dedicated crossing catheters to use below the knee, including the crosser and the Viance and the TruePath that are demonstrated here. But again, once you get in the subintimal space, your option for using re-entry devices are very limited. And the one on the market that I think is best suited for tibial re-entry is the Intier, and I'll highlight that when we get to that part of the talk. We've had other talks this morning about how to take quality pictures, and I can't emphasize the importance of taking good angiograms both at the beginning of your case and at the end of the case, all the way into the foot. Angulate your camera so that you can see multiple views. You can lay out the foot, lay out the pedal arch. A lot of these lesions are difficult to lay out, especially as they cross the ankle. So it's really important to angulate your camera so you have really good angiograms both going into and out of your case. Look for the delayed filling of those collaterals. It's amazing how many times there's ghost vessels at the foot that you can't see when all 3 tibials are occluded until you get really good quality pictures. Selective angiography is key. Getting a catheter down to the popliteal, injecting directly in the popliteal, as has been stated already today by multiple speakers, is really important. Sometimes you need to even go down into the collateral that supplies the foot and inject directly into that collateral to be able to see the distal reconstitution of these long occlusions. You want to define your inflow and outlet flow of your CTO and make sure you identify the target vessel that you're going after. In my practice, I'm mostly critical limb, and so I'm always trying to target that angiosome vessel, the vessel that supplies the wound bed. So that's usually going to be my first line goal if that's possible. If not, I'm going to go after the next easy tibial to revascularize depending on where it reconstitutes. You want to commit, you want to go and you can't cross the CTO without getting your sheath in, determining your access. We've had really good talks about that already today. Look for those hibernating vessels, choose a crossing strategy. I think it's really important. One of my tricks that I teach my fellows is when you're trying to engage the cap of a CTO, it's really important to get a catheter, a support catheter, all the way down to just on top of that cap and directly inject dye right on top of the cap. Rotate your camera in multiple views so you can see that little nub where you can get started in the native vessel. It's easy for those, especially hydrophilic wires, to slip off into a side branch because these CTOs often thrombose up to the largest side branch. So it's really important to get started into the true native vessel. So that's one of the most important decisions you can make at the beginning of your crossing is where you engage the proximal cap. I'm going to be doing directional atherectomy in just about all my cases. So I'm trying to cause as little trauma to the vessel, and especially in a tibial. We were just looking at stent data. In my personal opinion, you never want to try to put a stent below the knee. So I'm trying to get a good result below the knee with debulking with atherectomy and balloon angioplasty and not place stents in tibial vessels. And then one thing I struggle with, because I'm really hard-headed, is I tend to try to stand there and make something work that's not working. If what you're doing is not working, change your strategy. I'm going to show you some examples of the ways that I treat and cross CTOs below the knee to try to stay out of the subintimal space. You can see in this particular case, you've got a really nasty tibial occlusion. All three tibials are occluded. You can see that you've got occluded anterior tibial. And so I actually got into the vessel with a support catheter and injected directly into the vessel. And you can see we've got a fairly favorable proximal cap there. And so in this situation, I'm just going to use a soft wire and a support catheter. So I really like nitinol tip wires. So the nitrix wire or the command wire are soft nitinol. The tips are very resilient. You can abuse the heck out of them and they don't get all dinged up like other stainless steel wires. And so you can see I'm just supporting this nitinol tip wire. And you'd think I was going to have to get really aggressive with the CTO, but I popped right through that with a very low gram weight nitinol tip wire. And then after directional atherectomy, you can see we got a really nice result in that anterior tibial. Here it is after we finished completion angiography at the conclusion of our case. This was an occluded anterior tibial. It looks basically, like we say in my lab, the way the good Lord intended it. This is another just awful case, toe wounds in a patient with all three tibials occluded. You can see there's really nothing there to tell you that we should really be going after anything, but I can really encourage you to go after these patients without any revascularization. This patient's not going to heal anything. And so if you look at very delayed filling, you see a distal perineal show up. So I was like, well, let's just poke at this tibioperineal trunk and just see what happens. So in this situation, especially in the proximal perineal that has a lot of side branches that love to take your wire out of the true lumen, I like a looped, very soft wire. So again, I'm going to take a nitinol tip wire, support it with a catheter, and you can see this is real time, the case. Support catheter, looped nitrix wire, and then you just pushed, and we're across. And so, I mean, that took about 5 seconds on a case that a lot of people may not have even probed at with a wire. Got really across it fairly easily. And after directional atherectomy, you can see a really nice perineal, which was down, provided both communicator collaterals to the foot and was actually able to heal the toe wounds. Again, looped wire to avoid these side branches. You can see a hydrophilic wire would be very likely to slip off into the side branch, and that's how you end up with a perforation, a wire perforation below the knee. So I like to knuckle the wire and get past those side branches. I could not push it through because there was so much calcium here. So after I got past the side branches, I switched out to a straight, stiff glide wire. And so in that situation, I was able to cross the occlusion and then recanalize it with directional atherectomy. And you can see here, we've got a really nice result in that anterior tibial. This patient had multiple wounds, actually. You can see there was a high-grade lesion in the posterior tibial that we treated as well. So this patient actually ended up with perfect three-vessel runoff to the foot. They did very well. So what if you cross and you end up in the subintimal space? What are your options for trying to get out of the subintimal space? This is an occluded tibioperineal trunk, and once I got down, you can see my wire is to the lateral side of the true lumen. So once I'm in that situation, I like to use a stiff wire to try to poke back into the true lumen. My personal favorite is the Confianza Pro. So in this situation, you just redirect your wire. You know the true lumen is to the left, so you just redirect your wire there and you poke right in. So easy way to escape the subintimal space in that situation. After directional atherectomy, really nice result in that tibioperineal trunk. Another long occlusion, you can see reconstitutes at the foot. I used loop technique, but once I got down to the distal reconstitution, I was to the left of the true lumen, screen left in the situation of the true lumen, so I can't get back in. So you can see I'm parallel to the vessel right here, so I'm going to bring my wire back up and see if I can re-enter at that distal cap. So again, I like a Confianza Pro in this situation. So I pull the wire back, redirect it. I know the true lumen is to the screen right, and you can see it just pops right in. Once I get down to the foot, we really didn't see much of a dorsalis pedis on the original angiograms, but once I do a selective picture after I've crossed, you can see we've got a really beautiful vessel down at the foot. So once we open the occlusion, After directional atherectomy, you can see really nice result. Now we got straight line flow into the foot. Really nasty occlusion. To me, these are some of the hardest ones to try to cross. Antegrade is the anterior tibial that's occluded in the bend of the AT. This is a patient with toe wounds, but really nice vessel once you get to the ankle. So again, try to cross, and I actually used a crossing catheter in this situation. This is a Viance. But once I got down to the reconstitution, I was not in the lumen. You can see the catheter is actually not in the true lumen. And despite using all my usual wire techniques, I was not able to get back into the true lumen just using a wire. So at that point, you've really got two options. You could stick the foot and come up retrograde, which is a very realistic option. Or in this situation, you can use a reentry device. Like I said, really the best reentry device for below the knee reentry is the anterior catheter. The anterior catheter, for those of you who do coronary CTOs, is just like the Stingray. They were developed by the same company originally, Bridgepoint Medical. But it is a flat balloon that has wire ports to each side and 180 degrees. So you actually inflate the balloon in the subintimal space, and there's going to be one wire port pointing toward the lumen and one wire port pointing directly away from the lumen. And your job is to just select the right port and then use the special proprietary wire that comes with it and poke back into the true lumen. So this is a cartoon of how that works. Well, it played yesterday. I guess it didn't. The computer didn't have a good night, I guess. Anyway, so this is the balloon inflated in the subintimal space. You can see the actual true lumen is to the left of the balloon in that situation. So you can see the nice hook on this wire. Once I bring the wire down through the anterior, you can poke back into the true lumen. And now we have wire control of our CTO, and you can treat it with whatever modality you deem appropriate. I personally really like to use directional atherectomy when you compare it with reentry techniques, because you can use the directionality of the device to shave out your dissection flap. So in this situation, we re-entered at 20, and you can, just distal to 30. You can see our nice distal reconstitution. It goes into the foot, supplies the pedal arch. And this is, after directional atherectomy, this is the re-entry site. So no flap, no filling defect, really nice lumen, and no need for a stent. This is an example of coming retrograde. So again, popliteal occlusion, really nasty occlusion, only reconstitutes at the bifurcation of the PT and the perineal. No really visible AT there. So we came up from the posterior tibial access. You've heard a lot about pedal access already this week. Come up from posterior tibial access, do a selective picture, and you can see we actually have a little micro channel we can get our wire started into. However, after coming from both above and below, this is very unusual in my lab, but what we've found, because we can usually cross these retrograde fairly easily, in this situation, even retrograde and antegrade dueling catheters, I was unable to get the catheters into the same technique, into the same tissue plane. So you've got a couple different options there, Safari, other things. And in this situation, what I elected to do is bring an anterior catheter up from the pedal access just through a 4 French sheath and re-enter into the true lumen upside down. So that's what we did here. You can see the anterior balloon is inflated from the posterior tibial access. The anterior wire comes in. We just poke right in. You can see it goes up, follows the wire that's coming in from above. And now we have wire control. We just snare the wire, have body floss, and now we are able to complete our recanalization of popliteal with directional atherectomy. And after, I believe in taking the sheath out, your pedal access out before you recanalize the CTO. That way you have a low pressure head. Getting hemostasis is no problem whatsoever. And you can see this was our access site in the posterior tibial. Looks really good. I'm going to skip through this case and skip to the last case, since we're running out of time. This is a technique that you'll hear a little bit more this afternoon. This was a patient with a really nasty looking foot. She had already had above the knee amputation on the other side, so we're really wanting to be aggressive trying to save this limb. She has no patent vessels below the knee, really high-grade popliteal lesion. The only thing that reconstitutes is the perineal. So complete occlusion of the tibioperineal trunk into the perineal. I was unable to get through this antegrade, so I kept getting subintimal, and the wire kept wanting to go out this direction. I could not get it to track into the perineal. We have this really nice collateral to the side, so I was able to come through the collateral and loop the wire up through the through the CTO and crossed the CTO retrograde, so I was able to avoid perineal access. I'll actually be talking about perineal access this afternoon. In this situation, I was able to come through the collateral and avoid having to get perineal access, track the balloon through that tract and able to predilate, and then I was able to get a wire down antegrade into the perineal. Once we did that, we were able to do directional atherectomy, balloon angioplasty, end up with nice straight line flow into that perineal, which really ended up reconstituting the tibials at the foot, and the patient was actually saved. We were able to save that limb. So with that, I'll conclude. Remember, these are very difficult lesions to cross below the knee. You need to put a lot of tools in your toolbox. Don't give up. And if you end up in the subintimal space, don't panic. Just use one of the tools. Then once you get wire control of the vessel, you can treat it just like any other stenosis. I'll wrap up with that.
All right.
Thank you, Chuck.
Very good. I think we should have T-shirts next year that say, keep the foot out of the bucket. I like that. All right, Dr. Davis is going to talk to us about OCT-guided therapies.
Thank you. Just my disclosures again. So when comparing CLI and to non-CLI, I think we've seen a lot of CLI cases here. What I basically have come up with is that, and I think these are very true in terms everyone would agree, most have multi-segment disease, and it's usually infrapopliteal at some certain point where the occlusion is. It's typically occlusive, it's not stenotic, and there's usually a lot of complexity, multiple morphologies, angulations that you have to deal with, so which makes this difficult. It's almost always eccentric, and when you have total occlusions, even if it's not eccentric, when you go through it with your wire, you make it eccentric, and so you're always dealing with eccentricity. These cases are very time-consuming. I hear everyone talk about, we saw some quick cases there, but you hear everyone say, oh, 2, 3, 4 hours. So they can be very time-consuming, and usually you have less treatment successes with CLI cases than you do non-CLI cases, and correspondingly, you have higher complication rates due to longer times on the table, more die. Most of these patients have chronic kidney disease and all these other problems. So if you look at CTOs, one of the advantages surgeons have, they actually get a chance to see what these things look like when they're cutting them. We don't have that aspect of it. So it's got to be pretty nice to be a surgeon and actually see what you're doing. But you can see this is cut through SFA, CTO, and you can see the multiple caps. You can see there's openings and occlusions there. There's multiple different morphologies looking at this, thrombotic, plaque, some calcium. So this is exactly what you're going to be seeing as you're treating these patients. The problem that we have is that I heard trying to stay out of the subintimal space, but I'm looking at a totally occluded vessel on the left-hand side. I have no idea if I'm in the subintimal space or not, and I would believe that most people actually do get into the subintimal space if they're wiring that SFA on the far left-hand side. The different modalities that we have are IVUS and OCT, which you can see on the right, and we're actually looking at the inside of the blood vessel. And I'll show you that one middle one with the IVUS on the middle. There you can see that cyclic area on the bottom. That's actually from a wire attempting to cross a total occlusion. This was a re-entry above that. That's where a wire had got subadventitial and caused a perivascular hematoma. You see them all the time. If you put some IVUSs down your wires, as I've been told, it almost looks like a bomb goes off. The other thing that you can't appreciate when you're going down with wires is there's a lot of angulations to these vessels. We're not looking at straight. We have pretty stiff, straight wires that have to go through these angulations as well, too, which I don't think we don't think about that with all the angulations because we're looking at a two-dimensional screen when we look at fluoroscopy, plus the exposure to radiation that we get with all these time-consumings. Now, I'll garnish, if you look at this on the right-hand side, again, you see a catheter coming down there through a total occlusion. I could put that catheter on top of the leg, and you wouldn't be able to tell the difference if it was on the top of the leg or in the vessel, and you have no idea if it's in that subintimal space. But on the right, if you have an OCT-guided therapy, you actually can see the inside of the vessel, and you know exactly where you're at, especially when you can define borders as you can. You can see on here, this is within the vessel. You can see it from 9 o'clock to 12 o'clock is medial areas, and so you certainly know that you're in there. The other thing is we think that we cause smooth lumens with causing all our atherectomy devices. Well, let's look at what happens. If you have maybe calcified vessels and put orbital atherectomy in there or a soft plaque that you're trying to shave it off, you might not have problems. But if you direct the therapy with the wrong device, you get horrendous dissections. This just gives you an idea of what laser, orbital atherectomy, and angioplasty can do to an inside of the blood vessel if you don't choose your appropriate therapy. As I said, these are time expansive procedures that we do. CLI cases are typically multi-level, as you can see. Median fluoroscopy time goes up as you look at CLI cases. And that's why I say you can have multiple hours of doing this with multiple dye injections causing higher incidence of complications. We looked at our approach with using the Ocelot, which is the OCT guided that you saw there, putting that, and we actually looked at 16 cases without, trying to use no fluoroscopy. And as you can see, on our diagnostics and our therapeutics on the right, compared to our crossing fluoroscopy and our crossing times. So we were actually able to save time in these patients, which will, I think, ultimately reduce complications, plus reduce the amount of dye load that you're giving. We looked at some of our other devices, Ocelot, Crosser, Frontrunner, XP, Pioneer, and Outback for looking if you had to. And you can see the CTO crossing time and the crossing efficiency. And maybe in this bar graph, it gives it a little bit more outstanding idea. Outback and Crosser are additive times to this, not the using them to cross. But you can see that the times that if you use OCT, you can really limit fluoroscopy as well as, I think, procedural time in that sense. We kept on looking at our procedures after that. After the 16, we went on looking further. We had good lesion lengths, total occlusions. Our fluoroscopy time really stayed low. Our procedural time stays low. And again, if you're not dealing with subadventitial areas, I think your therapeutic time is going to go down too. If you're not dealing with trying to re-enter into from a subadventitial space, or if you're actually treating within the true lumen and you're not actually treating in that media or adventitious space, you're probably going to get a much better result with whatever you use, and you're going to have more options to do it. This is an example of a case study. This is an infrapopliteal lesion, and as you can see, total occlusion infrapopliteal coming down through there, and you can see some faint collaterals coming down into the perineal and tibial branch. This is the proximal cap with the OCT, and I'll play it in a second, but what you can see is, since this is a smaller vessel, you can see really layers from 9 o'clock down to about 5 o'clock. That's the layers that we're looking for. That's healthy medial tissue, and all this other stuff above is that. So you can direct this catheter, that middle marker there that you see at 2 o'clock, the catheter directs away from that. It's got a little bend on it. It always directs away from that. So you can actually look at where media is and actually direct it away from there so you avoid going into that medial layer. And again, looking at what you're treating. How do you know what's in there, the composition? You can see this. We have visible calcium, but this is not all calcified within the vessel. Look at this. This is medial calcinosis, where you have it in the deep wall tissue. And so most of this is fibrotic and most of this is plaque, but this calcium that we see there is all deep walled. As you can see, as we go through there, as we're advancing down through there, we're going past that calcified area and staying within that lumen itself, reducing time, reducing fluoroscopy times, as well as reducing, I think, complications potentially if we stay within this lumen. So you can see what, on the right without calcium, that you can see media what it would look like. You can see the lumen at 7 o'clock, and on the left where you can see that calcium. And actually, if you're actually doing a wire crossing, if you loop it up like we've seen, you'll actually probably, that calcium will help you stay within the vessel wall itself. Again, post-crossing and treatment, we're able to get a nice result coming down through there. So again, I think it helped us out there. So on crossing catheters with OCT, I think you can see the benefits of that. Now we have coming up Pantheris, which is going to be an atherectomy catheter, which is going to have the similar thing. And you can see the blade that cuts there, it's directional, and it's got that circular imaging factor right behind it. So this is going to be the OCT imaging, where you're actually going to be online, able to see what you're cutting as well. Anything that we do, again, if we have a total occlusion, we're going to have to continue give puffs of dye. You're going to be giving dye as you come down through there. And if you don't need to do that, as you can see on that right-hand side, this is cutting as it's going through there. And you can see now at 9 o'clock media, you can stop your cutting right there. You're not going to go into the wall. You're actually going to be able to cut what you want to cut. And And I think I would be a proponent that that's a lot safer and less complications, less dye, less time on the table. Again, you can see this was a totally occluded vessel on the left. After treatment, you can see that, and this is the atherectomy tissue that was pulled out. And if you we actually did histology on it, and there was roughly 5% media component in this. 95% it was all plaque, and there was no intima. So again, I think this will give you an idea of what you can. And look at the it looks almost aneurysmal. If you would have thought that you did this with a directional atherectomy catheter, you would have thought you went real deep, but we didn't. So if you think about this bar graph that I put up before, diagnostic fluoro on the left, crossing fluoro time in the middle being reduced with OCT, therapeutic fluoroscopy on the right. If we could reduce that by half, look at how much time that you could save on your case, on your fluoroscopy, and I think you're just going to have a much safer aspect. So in conclusions, I think OCT-guided therapy has benefits in CLI by potentially reduction in overall case time. I think OCT defines a medial and adventitial structures where you can't fluoroscopy. It's impossible. You don't know it. OCT-guided crossing makes it possible to stay true lumen, and you know if you're in the true lumen or not. Maintaining the true lumen enables your operators to have better understanding of what's going on and how you can treat this, drives treatment modality. And I think OCT therapy may reduce complications that arise due to longer times, dye constraints, and what the complexity of the disease that you're actually dealing with. Thank you.
All right, we're going to move on to the next case. I'd like to introduce Dr. Greg Stanley. He's a vascular surgeon from the University of Mississippi. He's going to talk to us about recovering from disaster from distal embolization below the knee.
Good morning. Thank you, John. Appreciate the opportunity to be here. Truly appreciate being a part of CVC this year. I'd like to talk to you about distal embolization, which is a topic obviously that can spark fear and even the most obstinate interventionalists. What we know is that distal embolization happens universally in almost every case that we do. And if you do it long enough, you're going to have a situation where you're going to have to deal with it. And what I'd like to offer today is perhaps an algorithm that I use in my practice, and that perhaps that you can apply to cases of distal embolization. Clearly, when this happens, it can be a significant thing not only for yourself, for your patient, but in terms of procedure time, cost, radiation, contrast dose, hospital length of stay, including possible ICU stays. These clearly are significant issues that will come up with distal embolization. We're all aware of the cheese grater effect that happens not only with balloon angioplasty and stenting, but also post-dilation of your stent, and can lead to distal embolization during your procedure. Several groups have looked at rates of distal embolization during endovascular procedures and have found time and time again that embolization happens almost universally. In 2007, Doppler hits were seen in all three types of interventions, including atherectomy, angioplasty, and stenting. Looking at debris in your filter after an intervention, you can see that all three modalities create distal embolization. And even going further to look at angiographically significant distal emboli occur at a much lower rate, but certainly still occur and can affect your case. The cost is significant. If you have a distal embolization during your case, you can add at least $6,000 onto your case, even with a full recovery. If that patient goes on to have further procedures because of that embolization, you're looking at somewhere between $15,000 and $25,000 added on to your case. It's obviously something that needs to be looked at. Your risk factors for distal embolization can be broken down into two categories: your patient characteristics and your lesion characteristics. On the patient side, you have a higher risk of having a distal embolization the sicker your patients are, which makes obvious sense. But patients that come in with critical limb ischemia, meaning 0 to 2 runoff vessels or prior amputation, would all suggest that they have more advanced disease and are therefore more likely to embolize distally. In addition, acute symptom onset would suggest that there's some underlying thrombus in the lesion, which again has a higher risk of distal embolization. When looking at lesions, it would be the things that you would think about: chronic total occlusions, TASD lesions longer than 15 centimeters, highly calcified or exophytic lesions, and then again thrombus. And stent stenosis is an interesting, different morphology, but also has a very high rate of distal embolization. As John mentioned in his talk, and several other speakers have mentioned, it is critically important to take pictures from the aortic bifurcation to the toes before you start and when you finish. Distal embolization is not always obvious unless you go looking for it, but especially in patients that have critical limb ischemia. If you embolize to that collateral that you just revascularized, that's going to be the main blood flow into their foot, you can have a great proximal result and still have a patient that's not going to heal their wound. You have to go looking for them. And most of these complications can be prevented. The first case I'd like to share with you is an 81-year-old gentleman that has ischemic rest pain and has a common femoral occlusion. I actually treated his contralateral side with a femoral endarterectomy. He got a very bad wound infection. He's an obese male. He was a primary caregiver of his family. He was out for about 3 months. After that, he said, no, thank you. I do not want another endarterectomy, but came in with rest pain of his left leg. And I was able to convince him at least to do an angiogram. And of course, he had an occluded common femoral on this side. Knowing that he was not going to consent to an endarterectomy, I elected to proceed endovascularly with him. So you can see his common femoral occlusion. His SFA runoff was fairly good. He had single vessel runoff through this, through his anterior tibial, all the way down to the foot. And after directional atherectomy and post-dilation with balloon angioplasty, we actually got an acceptable common femoral result. SFA was very nice at the end, and unfortunately, this was our runoff picture, and this picture still takes my breath away every time as I remember it distinctly. And initially the thought is, uh-oh, what am I gonna do? A panic. Well, the key is don't panic. Take a deep breath. If you need to change your underwear, change your underwear. But take a step back. You have some time. This is a leg. It's not a brain. Take some time. Review what you know. Determine what your goals are in the case. And then have an algorithm and use it. So review what you know. Why are you here? Is this patient a claudicant? Is he here with rest pain or tissue loss? And that very much will determine how you approach this problem. Go back and review your initial angiograms. See where the problem is. See what you've lost. See what you need to get back to get out of there. And finally, if you have a filter in place, take a good look at that filter and see, is the filter full? Is it properly deployed? What's going on with the filter? Determine your goal. If this patient is a claudicant, this maybe is the most stressful situation because this patient walked into your lab or your OR, and if you don't do something, this patient has a very high potential of losing his leg from this complication. What you would ultimately like to do, obviously, is to return to his initial angiogram, but that may not be possible. And in claudicants, almost always, if you can at least get back a single vessel runoff, not ideal, but if that's what you can get, then that's what you take. Now, in rest pain or ulceration, you have to go back and look at your initial angiogram and determine what collateral network is present, which will tell you what you can hope to achieve. Your goal, again, is to get back to the initial angiogram runoff, but again, single vessel runoff to the foot should be enough with your more proximal intervention to improve the patient before you leave. Those patients that you're treating for limb salvage, they can't get worse off. They're going to get amputation if you don't do something. And so your ultimate goal is to get something into the foot. But if it doesn't work, these patients are the ones where you literally can throw anything and everything that you have, including the kitchen sink, to try to save their leg. So the first thing I do is ask, what is the last ACT? You have to make sure that your distal embolization doesn't propagate more thrombus, which will make your job entirely more difficult. So I give additional heparin. I ask to follow ACTs. Define your situation. What vascular area are you dealing with? Do you think you embolized atheroma? Do you think this is thrombus? Is it a little bit of both? Do you have diffuse thrombus everywhere? And again, look at your filter. Also, you have to consider your access. The larger your access, the more options you have. You have a lot of tools in your toolbox. And over the last year in my practice, I have used every single one of these to deal with distal embolization. And you don't have to be facile with all these, but if you have a good algorithm and you can get knowledgeable and comfortable with a set of them, they will get you out of a lot of trouble. So first step, selective angiogram. You've heard this the entire conference. Cross the occlusion if possible. If you get heme after you cross the lesion, it's okay to inject. Place a filter below. I like to start with suction thrombectomy using a priority 1 catheter. They have a 6 French and a 7 French option, which is a rapid exchange catheter that allows you to suction out anything that may be in the lumen. I then move on to a 5 French catheter, usually with an angle so I can direct exactly where my suctioning is going. And the next step is to move up to a coronary guide catheter, which is a 6 French catheter, basically a garden hose that you can suck out a lot of material. And finally, if you think you're dealing with thrombus, and angiojet is a very good option. Balloon angioplasty and provisional stenting as needed. Tibial algorithm is almost entirely the same, with the exception of the coronary guiding catheter is a little bit difficult to get into the tibials. There's also 2 additional techniques you can use, which certainly are off-label, but a filter scoop technique, whereby you pull the filter back to collect debris, and then also provisional atherectomy, if that's something that you feel comfortable doing. So going back to our case that we had a gentleman that embolized to his popliteal, crossed the lesion into the anterior tibial, did a priority 1 suction catheter, and got a nice amount of debris out, and had very nice runoff to the leg. I could have stopped here. He did have flow into his cerebroperoneal trunk to start with, and I wanted to get him back to that, so I catheterized his TP trunk. Again, did more priority 1. Sorry. And ended up with a very nice result here. Returned him to his baseline. Next case, just to illustrate another case of embolization, a gentleman also with rest pain, SFA occlusion, reconstitutes above knee popliteal. You can see his runoff here. Dominant dorsalis pedis, or anterior tibial to the foot. I recanalized him with directional atherectomy, Hawk 1. I had a spider down, but you can see right at the joint line here at the bottom of this picture, still had a very tight stenosis in his popliteal. I couldn't reach that with the directional atherectomy device. So elected to put a filter into his anterior tibial and treat the popliteal, which turned out very nice. But you can see in the tibial-peroneal trunk on the right side of the screen something funny. As I came down and looked a little bit closer here, you can see there's embolization in the TP trunk. So once again, cross with the catheter, take a picture. You can see the vessels patent below that, so I need to do something more proximal. I put a filter in to protect any further embolization, priority 1 to suction, and got a fairly nice result. You can see on this right side angio, there's a little linear filling density here, which I couldn't tell if that was a strip of atheroma I'd shaved off from above or if this was a piece of thrombus. In any case, I attempted more priority 1, was not making much progress, switched over to the 6 French MPA coronary guide catheter, was not making a whole lot of progress there. So I elected to use the filter scoop technique, essentially pulling the filter back up into the catheter. Have a little bit of spasm from doing that at the vein, but you don't see that filling defect anymore. And a final picture, spasm, did a little balloon angioplasty, and final result looked very nice with good runoff to the leg. I'll spend just 2 seconds on putting a filter in. An ounce of prevention in these cases really is key, and if you don't have the option to use a filter in every single case, these are the cases that you really strongly should consider using a filter in. Heavily calcified lesions, exophytic plaques, in-stent stenosis, again, all lesions that have a very high risk of distal embolization, and then the patient, single vessel runoff, tissue loss, or long occlusion. If you do have a filter in place, you want to take a good look at the filter at the end. You can see this angiogram of a thrombus sitting just above the filter. If you try to capture this filter, you are almost certainly going to embolize that piece. So you can use the same techniques, double stick your sheath, put another wire and priority 1 catheter down there to suction thrombectomy within the catheter, within the filter, and suction that out. You either push it into the filter or you suction out the debris, end up with a nice result and recover that filter without a problem. And finally, if you are not making progress, always get a second set of eyes. Maybe they can direct you somewhere else. And ultimately, if you still are not making progress, surgical revascularization may be the only option, and it should be very strongly considered before ending the case. Thank you.
All right, I'll come over this one. All right, excellent talks there. He didn't tell you the joke there, Dr. Fogarty's wine there. But anyway, okay, well, if there's any questions, please step up to the microphone. We got a couple minutes here, but just take this moment to thank everyone for excellent discussion and talks. The live case, we're not going to be able to go back to. They had an emergency, and they had to take the patient out of the room for another case, so we'll hopefully get us some follow-up later today. Quick thing, 2 lunch symposiums coming up. There's one from Bard about drug-eluting, drug-coated balloons, and Lucerne 1 and 2. And Lucerne 3, quite interesting discussion. If you've been stuck in the arterial room and haven't gotten to go over the venous room, you can hear about this new venous seal closure system for doing venous reflux. Quite interesting. Actually, the person speaking is the really smart guy who invented it, so you might want to check it out. Any questions for the panel here, quick? Or y'all are hungry? All right. All right, thank you very much.